Welcome everyone to the Eczema Association of Australasia Inc. and Eczema Association of New Zealand Inc.'s first live Q&A webinar for 2021, all about eczema and babies. My name is Michaela Vandenberg and I'm a Corporate Membership Officer for the EAA and EANZ. Thank you for taking the time to join us today. We hope you learn some great tips, information and resources for how to effectively manage your baby or child's eczema. To begin, I'd like to introduce you to our panelists for the day. Cheryl Talent, Special Dermatologist Dr. Kate D'Ambrosis from the Mater Hospital and Valley Plastic Surgery, and Paediatric Dermatology Practitioner at Children's Private Medical Group and Melbourne Neonatal Network, Emma King, who will be providing you with some great insights into eczema in babies and how you can effectively navigate this condition. There we go. In today's session, we will learn more about the EAA and EANZ and Dr. D'Ambrosis's and Emma King's experience before we head into a Q&A session. If you have any questions while Dr. D'Ambrosis or Emma King or Cheryl Talon are presenting, please be sure to write your questions in the chat on your control panel. We will then be responding to these questions in our Q&A time. If we run out of time and I'm unable to answer your questions, please send them through to either help@eczema.org.au or give the EAA a call on 1300 300 182. This session will be recorded, so please, we will be sharing the audio visuals from the webinar onto our website and socials. So if you need to refer back to this once the webinar is over, please head to the website. We hope you learn a lot from today's session, and we welcome any feedback in our post-webinar survey you will receive once the session has concluded. I will now be handing over to Cheryl Talon, who will provide a little bit of background on the EAA and EANZ and the importance of understanding the condition for yourself, your baby, and your loved ones. Please welcome Cheryl Talon.
Hi everybody, and welcome today. It's really great that you've tuned in, and I hope that you really take away some great points to help you manage your baby's eczema. So I wanted to talk a little bit about our role as a support group. We run a group in Australia and New Zealand, and what we like to provide is support and education for eczema sufferers and carers, along with the wider community in all aspects of eczema and its impact. There's no simple solution for eczema, but there is good help available. So the EAA and EANZ are both non-profit organisations, incorporated bodies, registered charities in New Zealand and Australia, have public benevolent status, a medical advisory board and international links. This is so that we keep up to date with everything happening in the dermatology space and specifically eczema, so we can pass it on to our members and the public and hopefully give them some better choices. We know that managing eczema to prevent flares is a constant daily battle for all sufferers, even if they're mild, and specifically if their eczema is a lot more severe, and it can have a really major impact on daily life. Every year, we run 2 awareness campaigns, one in May, Eczema Awareness Week, and one in September, Eczema Awareness Day, just raising the plight of eczema sufferers, for the public community, because there's still a lot of misconception about what causes eczema, why you get it, and what we can do about it. We're also proud members of the International Alliance of Dermatology Patient Organisations, Global Skin, which is a worldwide umbrella over all dermatological skin patient groups. And it is a great way to find out about new treatments, find out what other countries are doing to help their eczema sufferers. And so it's really valuable to be part of it. We're also supported by some wonderful companies. We wouldn't be able to do what we do unless we had their support, and also Queensland Government, because our main office is situated in Brisbane. We offer our members lots of tips on our social media channels to help manage their condition. We know that, you know, everyone's skin's different, so what works for one person may not work at all for the next, but it's great to get some general tips to really, you know, look at what you're doing day to day and get some, you know, some assistance. We also produce and distribute the only dedicated eczema magazine in Australia and New Zealand, Eczema Quarterly, and it's wonderful for people to be able to read up on certain aspects of eczema. You know, we get a lot of information from overseas, but we get a lot of Australian dermatologists and other health professionals writing information as well. And it's really helps our members to keep connected and feel as though they're not just being shoved aside and ignored or forgotten. Also, we produce and distribute our Caring for Your Eczema brochure, posters, and lots of patient information sheets. So if you get in touch with us, we can send you a range of tools which, you know, we're not medical experts, we can't get rid of your eczema, but we can really help you to manage it more effectively. So we know that approximately 1 in 3 babies develop eczema between the ages of 2 and 6 months. One of the reasons we wanted to do this webinar was our #1 amount of calls would be about new mums with babies. I mean, you have this lovely baby who's gorgeous, you take them home from the hospital and then all of a sudden they develop this unsightly rash. Everybody gives you advice and it's really confronting and confusing for parents to manage. So we know there's no cure for eczema, but it can be well controlled. It's very common for the severity of the eczema to change and essential to control it as soon as it flares up. For eczema that's difficult to manage, for eczema that's difficult to manage, it's always the first port of call is ask your health professional for help with an eczema care plan, or contact us and we can point you in the right direction. Secondary bacterial or viral skin infections are common in children with eczema. I know they're a bit scary, but we do have treatments that can really help deal with them. They may be prescribed an antibiotic or need more infection control, such as bleach baths. And most children with eczema can have all their vaccinations, including measles, in the normal way, including children who have egg allergy. Sometimes, however, the eczema may flare up a bit after immunisations. It's always best to talk this through with your health professional. One of the biggest misconceptions is using topical steroid creams. We know that they're very important sometimes to help manage the eczema, and the ones prescribed for babies are usually of a very weak formulation. They can reduce itchiness and speed up healing. They're very useful in controlling a flare-up and safe to use as prescribed. Moisturising the skin is very important. This keeps it supple and less likely to crack and also helps relieve itching. Always wash your hands before applying creams or ointments. Thin, loose cotton or bamboo clothing helps to avoid skin irritation. Dress babies in layers so they do not overheat, as we know that heat is a huge factor. Eczema as a disease for a little baby or even for a toddler can be very frustrating for parents to manage on a daily basis. Relatives and friends often offer advice which is well-meaning but often causes more stress. Please follow the advice from your health professional. If you're not sure about what your health professional has told you, give us a call, send us an email or visit our website and let us help you. Thanks so much for listening today, and do remember we're always here with a friendly listening ear and a shoulder to lean on.
Thank you for that, Cheryl. I would now like to introduce you to our next speaker, Dr. Kate D'Ambrosis.
Great, so I'll get started. Thanks, Cheryl, for that. I've come along today to talk a little bit about managing eczema in children and in babies particularly. And as a dermatologist, I'm often one of the first ports of call for little ones with this chronic disease, as Cheryl so brilliantly put out, our goal is control, not cure. So a lot of my first interaction with patients and their parents is explaining just that, explaining the genetics of eczema. So my aims today are to go through a bit of the underlying pathophysiology of eczema, look at some of the genetic factors briefly, recognise how eczema can look different in different age groups, particularly in babies compared to toddlers and younger children, and then highlight how we can better manage this chronic disease as a team. So I have no conflicts of interest to declare, and I work in private practice in Brisbane and also in public practice at the Mater Public Hospital at South Brisbane. So as I briefly said, we're going to look a little bit about what is eczema, why does it happen in baby skin, what are the underlying causes, how it can look differently across the different age groups, and how we can better target management to focus on those different age groups. So eczema is actually derived from a Greek word meaning to boil over, and quite literally that's what it does look like in the skin. It presents as these raised, red, itchy and raw areas with a predilection for certain types or certain body parts that change with age groups. It does usually occur in people who have an atopic tendency. So by that, I mean there's often a constellation of different medical conditions that tend to go hand in hand. And they are atopic dermatitis or eczema, asthma, and allergic rhinitis or hay fever. So when I'm seeing a patient for the first time, I often do take quite a detailed family history to help me put together the diagnosis, but also to exclude that these other issues may come up in their medical history and may require some attention to manage as well. The genetics underlying eczema really gained momentum with the publication of this article back in the early 1980s, and that was with the discovery of this particular gene called filaggrin. So filaggrin, which is derived from filament aggravating protein, is a term that is used to describe this protein coded for on the first chromosome that has a very important role in managing the stratum corneum and the outer layers of the epidermis. So that's a component of our skin that is really vital to forming a good barrier in the skin, and is first and foremost one of the biggest deficits in atopic dermatitis. So particularly the severe forms, often there'll be an underlying genetic abnormality in this protein, which means the keratinocytes, the cells that form the epidermis, aren't sitting together as nicely and as tightly as they can, which means the epidermal barrier is somewhat compromised and more open to insults and not coping with environmental stresses as a nice tight epidermal barrier would be. So I often, when I'm seeing some parents and a patient, I will use the analogy of the brick wall to explain what I'm talking about when we use these terms. So in healthy skin, where filaggrin is functional on that first chromosome, it means that the skin cells can sit together nicely, like a nice even brick wall. In atopic dermatitis or eczema skin, when there's a deficiency or an abnormality in that filaggrin protein, it can mean that the skin brick wall isn't as even as it could be. So it can be a bit dilapidated, it can be a bit haphazard, and it falls apart easier, which presents, as we see it in the skin, as scaly, red, eczematous-like lesions. I thought it might be helpful to hear directly from a patient rather than from me as to how this can impact a child and a family, because I think it's really important to see their point of view rather than just mine. So Michaela can press the audio on our video. We'll hear from my lovely patient, Amira. And as Cheryl alluded to, and I've alluded to as well, eczema does tend to present in this evolutionary pattern in terms of its skin distribution. So babies do tend to present with eczema that is more locally facially acquired, so it affects their cheeks and their chin. Toddlers tend to present with eczema more in ankle sites, and then that moves up the body as the child stands up and is more mobile. So toddlers and younger children tend to present with more flexually distributed eczema. These photos show quite a typical infantile young baby with eczema. So you can see this erythematous red raw eruption affecting bilateral cheeks in both children, and on the photo on the right, also on the chin. And as that becomes more chronic, more infected, more irritated by scratching and saliva, that skin takes on that thickened, cracked appearance as well. And that differs to toddler eczema, which often looks quite a bit messier. It's more excoriated as children are more angry with their skin as they get their fingernails into it, as they rub against things. And it tends to be in sites where their often skin is exposed to irritants like sand pits and grass, so the arms and the legs particularly. School age eczema generally seems to distribute in flexural sites, and we hypothesize this may be due to sodium chloride in sweat irritating the skin, so it collects in these areas and is a chronic skin irritant. But they also we also see a lot of facial eczema in school age children, probably related to facial touching with our hands, but other facial irritants that really drive that eczema. So I use this quite a lot with my patients in describing how to gauge their skin. I call it my traffic light system, but just working out whether their skin is green in a healthy zone and doesn't need too much treatment, but does need the regular barrier measures and maintenance measures we put in place, compared to an amber skin zone where the skin maybe is a bit red, a bit itchy, a bit barrier compromised, and then we tailor the treatment to the body site that's affected. And then a red zone where you need to seek quite urgent help because the skin barrier is quite compromised. Another question I commonly get is why use an ointment compared to a cream? So this is quite a nice summary as to the main differences. Generally, as dermatologists, we do prescribe a lot of ointments. So ointments tend to work better and faster. They're usually quite low sensitizing risk compared to a cream, very low risk of irritation, and they work well in sites which can be difficult to get a response, so where the skin is thicker than other body sites like the face, the hands and the feet. Often ointments can feel greasier on the skin, so some patients can find that is detrimental or something they'd like to avoid. And when that happens, I think there's a lot more benefits to using a cream compared to no treatment at all. So it's completely fine to use a cream. You might just have to accept that you might not get that very rapid result that an ointment generally will have in very inflamed skin. And just to touch briefly on treatments that are coming up in the pipeline, dupilumab is very close to PBS approval, I hear. So this will be a really exciting development for eczema in kids particularly. So we're waiting with bated breath to hear about the outcome of a meeting in the next week or so. The other agent that is coming up on the horizon is another biologic drug. So potentially we could have 2 injectable treatments for eczema in the next decade, which will revolutionise our treatment of eczema, hopefully do away with a lot of the messiness and the cumbersome cream treatments that we do go through to get a good result, and hopefully improve our kids' eczema overall. So thank you for having me today. and hopefully I can help with any questions later on.
Afternoon, everyone. Thanks for that, Kate. So today I work at the Children's Hospital and privately at the Children's Private Medical Group and Melbourne Neonatal Network. I've been working with children with eczema for the last 25 years and found it very rewarding, and that we can actually make a difference to children's eczema. So what is eczema? So Kate's gone into quite a bit of that, but the skin provides a natural barrier to control temperature, hydration. It provides hydration and protects against harmful substances from entering the body. So with eczema, as Kate said, it's a little bit impaired. So the bacteria and viruses can sit on the skin a bit more. The skin's a bit drier. And it is more sensitized to things such as, prickly things like wool or tags, and heat in particular. It's the most common skin disease that your GP will see, and it affects about 30% of children in Australia. And unfortunately, we have the worst eczema probably in the country, down in Victoria. The most common onset is in the first year of life, and that's hard work because parents are generally new parents, adapting to having a new baby in their house and all the demands that brings, and then all of a sudden they've got an itchy baby that keeps them and is uncomfortable with the itch and inflammation and potentially skin infections. So with eczema, it's a chronic disease, although 50% of children grow out of it by 2 and 85% grow out of it by 5. But we have to help the children grow out of it. So there is no cure, but in fact, if you manage the eczema more effectively, then they've got a higher chance of growing out of it earlier. There's about 5 or 10% of children who will still have eczema as an adult, but the children with eczema will always have dry skin. So that's what Kate was talking about with the filaggrin deficiency. And they will always have dry skin and always have sensitive skin. So for example, if your child's grown out of eczema and then as an adult chooses to be a hairdresser or a concreter, they may end up having eczema on their hands because they've still got that sensitive and atopic background and dry skin. So the children are itchy. If it's not eczema, if it's not itchy, it's not eczema. And the itch is actually dementing for parent and child. So, and this is what keeps the children awake. Skin is dry. Some children are drier than others. So some children need more moisturiser than others, more applications throughout the day because they're more dry. It's also red, and the redder the eczema, normally the worse the eczema. And the redness is caused by the inflamed skin. We'll just get to go back a bit, if that's all right, Michaela. Thanks. So bacterial infections are common in children with eczema, and we know that children with eczema colonise the bacteria called Staphylococcus aureus, and this leads to itch and inflammation. And if the children scratch, they are easily infected, which is why we use our bleach baths. And if the better the management, the less dry the skin, the less the bacteria, the less the chance of an infection. With eczema, it's important not just to treat with creams and cortisones and moisturisers, but also to treat the environment. So there's no point putting your child to bed with cortisone and then moisturiser, then 2 layers of clothing and then a big thick sleeping bag and then the heater on, because it's not going to have much of an effect if you're overheating them. And it only takes about 10 minutes for a child to become hot and itchy. I normally say dress like dad rather than like mum, and just in 1 less layer than mums generally. So heat is a huge big trigger. So normally I say, even in Victoria, we have 4-degree mornings here in winter. If they want to wear 1 layer of clothes, shorts and t-shirt to school, they go to school like that. And one of the biggest problems that I find is that parents overheat their children with clothing and heaters and blankets. And just to keep in mind that we don't catch a cold from being cold, we catch a cold from a virus. And dressing your child in one layer of clothing throughout winter and summer is not going to make them catch a cold anymore. And I say dress your child so they're and treat your child's environment so they're not hot and itchy, they're not cold and freezing, but cool and comfy. Dry air also increases dry skin. So the drier the air, the drier the skin. And we find that the children who have an Asian or an Indian background tend to get better once they go back to the homeland for a holiday, and then they come back home, particularly in Victoria where we don't have a lot of humidity, but the eczema comes back again within a couple of days. So to overcome this, we use lots more moisturiser. Prickly rough fabrics such as wool, fine merino wool is fine, but woolen fibres that are nice and thick are more prickly. So remember to unpick your tags and get rid of wool unless it's fine merino wool. And as Kate said, dribble is a huge irritant. So lots of barrier creams, you know, zinc and castor oil cream. There are some fancier French products, but nice and thick around the face and neck. So often they go out of my consulting room looking a bit like Father Christmas, but it goes in pretty quickly and provides a barrier to stop the dribble irritating and sending off the eczema. So it's often linked with asthma and hay fever, and it can affect absolutely any part of the skin. And you can see this is actually my son, and he'd be horrified now because he's 20, but moisturiser needs to be put on nice and thick like this. So we need to have multiple treatments, manipulate the environment and have good controlled skin and start the flaring treatments ASAP, don't wait. And this will help the children go out of it a bit earlier. Next slide, please. So what does eczema look like? Red skin, rough skin, dry skin, inflamed skin, sometimes thickened skin like the bottom photo here. This is infected eczema, which is the middle right photo, which is crusting and weeping. It's important to remove this crust ASAP, and you can do that in a bath with something like a Chuck's towel, wiping it away. So it's red, dry, and this is thickened post-inflammatory skin. Post-inflammatory hyperpigmentation can also occur when the skin's been inflamed, and it can also go a bit whiter in colour, which often people say this is from cortisone, where in fact it's from the eczema. So this is quite common, the darker hyperpigmentation that occur in the darker skinned children. So it's red, it's excoriated from the scratch marks as well. It's always itchy, and it's the skin, the itch can cause interrupted sleep. So the more interrupted the sleep, the more impact it's having on quality of life, not only of the child, but also the family. So if treatments are put in place with a good management plan and adherence to the management plan, you can generally get the eczema much more controlled within 3 days of starting the treatment plan. And almost, 80 to 90% improvement. Next slide, please. So a few years ago now, I was on a panel of experts, and we published a consensus statement that is now on the Australian College of Dermatologists website. And the problem with cortisone creams is that they have a bad name for a bad reason. So cortisones are safe if used as directed by your dermatologist or nurse practitioner. And we tend to use a weaker one for the face and a stronger one for the body. Sometimes we do need to use stronger ones on the face, but just for a limited time. So we virtually debunked all the issues that the wives' tales about cortisone, and this is readily available on the College of Dermatologists website. So if you're interested in learning a bit more about cortisones, I suggest you have a look at this. These cortisones are needed, and the way we use them with eczema is if it's red and itchy, put it on. I actually instruct parents to feel the skin rather than just look at it before the nightly bath. And the reason for that is you can feel eczema before it even becomes red. So if you put cortisones on at the beginning of the flare, when it's rough skin like sandpaper, it may not ever get red. It may then not wake them up, and then they may not get infected. So, and much better quality of life with that. Next slide, please. So the role of allergy and eczema, a lot of parents would like to say, yep, take your child off dairy, take your child off peanuts, take your child off wheat, whatever, and the eczema will be fixed. This is not correct. So allergy is a trigger. It's not a cause of eczema. If you take your child off foods, it's not going to cure the eczema, and in fact can be quite dangerous. So if you feel that your child has an allergy, that's something that Kate and I need to do, is assess, do we think that the child has an allergy to any food, or as the child gets older, in any allergies in the environment. We'll ask the questions to see, do we think so? If we think so, then we will refer on to an appropriate allergist. And if the child's got multiple allergies, they do need to see a dietitian. So in most cases, the regular use of a good moisturiser, early topicals, cortisone, and removal of the environmental triggers will improve the eczema. Don't remove any staple foods from your child's environment because it can be dangerous. Food allergy, we normally suspect if babies have got bad facial eczema, or if they tend to flare with a hive-like eczema or just hives or very itchy, all three within 0 to 2 hours of eating the food. That's the most common type of allergy that we see with eczema children. If we think they need to be referred on, we'll refer them, and then they will have a skin prick test with the allergist. And then it's their job to teach you about how to eliminate the foods and when to reintroduce them, and when they need to come into hospital, sometimes for a food challenge as well. In young can have false positive tests or even false negative tests. So I've had some children who've had false negative tests as under 12 months, and then after 12 months of age may come up with a positive result to that food. Next slide, please. So principles of management. So you must remove heat. Anything that makes the child hot, we must so pare down the layers. I always say 1 layer in the middle of winter in Victoria, 1 layer inside, 1 layer to bed, and 1 layer in the car, and like a Bonds hoodie outside. The amount of parents that come in with 3 layers of clothing on in the middle of winter, a hat, is huge. And so teaching the parents and giving them support to say it's fine, your child's not going to catch a cold, is very important. Prickly things, as I said, aggravate, and allergies can be a trigger as well. So we must put moisturiser on from top to toe, even if the eczema is clear, because remember, they've always got dry skin, and we do it nice and thick because half of it will get wiped off as well. So we must use steroids aggressively. So at the beginning of the flare, pop it on. As soon as the skin becomes nice and smooth and the redness is gone, then you stop the cortisone, but remember to start it back again as soon as it flares. With moisturisers, I actually tend to use creams more than ointments, and there are some really, really good creams available now in pharmacies. Go for the pharmacy creams rather than the supermarket, because they do tend to be better quality products. And I tend to use good quality products rather than the cheaper products, because you do get better outcomes. So you probably end up spending about the same amount of money anyway, because you get better control and better outcomes without having to put it on too many times because it's not as good quality. Wet dressings, which are these wet dressings here, can sometimes, or wet clothes, you don't need wet dressings, can be applied if the child is not sleeping or if they're very itchy during the night. So for example, the little baby that's very red, if they came and saw me today, I would be saying you need to put wet dressings on your child, but only for 3 to 5 nights, because we need air, we're not fish, so we can't be in water all the time. And it's something that is cumbersome for the families to use. But generally, if you do your bleach baths, your good moisturiser, your aggressive topical steroids, and you really only need wet dressings or wet clothes for about 3 to 5 nights, and you might need these on and off. And you can always put a dry layer of clothes on the top, but once again, don't overheat because overnight they will dry out. Now, if they're dry, never wake a sleeping child. Leave them on, and then when they wake up, take them off and put moisturiser on. So with treatments of skin infections, always remove the crust. There's no point just putting a child on antibiotics if you don't remove the crust. And the easiest way to do that is to pop them in a bath, get a chuck towel that you do the dishes with, wet it, and just wipe the crust away. And sometimes it can bleed, but that's not a problem. You can, and that's the area that you need to put the cortisone on. So if there's any open eczema skin, then you really need to put cortisone on there. A lot of people are scared to do that, but that's important because that's the worst area. So as soon as you wipe the crust off, get out of the bath, put your cortisone on, moisturiser, and then a wet dressing if needed. Sometimes we do need to put children on oral antibiotics, but with the institution of the bleach baths now, we're using less and less antibiotics, which is really good. But if they're needed, they're needed. And we don't tend to use topical antibiotics because of the risk of resistance. Only if they've got bacteria up the nose is when we use topical antibiotics. Bathing is very important, and it's just as important as putting the cortisones and the moisturisers on. So every day, and make sure they sit in the bath for about 10 minutes. And sometimes we put the children in 2 baths a day. And if they're very infected, I will actually do 2 bleach baths a day. And I put salt in my eczema baths because salt is anti-inflammatory and anti-itch, and also it stops stinging. So at 10%, water can sting. As you know, if you get a paper cut, hop in the shower, it can sting. If you put salt in the bath, then it actually helps to stop that stinging, and then the children enjoy the bath a lot more. Sometimes we need to use other options, as Kate was talking about before with the new treatments that are coming on. Sometimes we need to put children into light boxes and on immunosuppression medication, but that's only for the really small minority. And if you're not getting help from your GP or maternal child health nurse, then ask to be seen by a dermatologist or a nurse practitioner. Next slide. So with eczema treatments, every day avoid the environmental triggers, cotton clothing and blankets, moisturise nice and thick top to toe twice a day, a daily bath with salt and bath oil. Vitamin D, there is evidence to say that, particularly in Victoria, that vitamin D is one of the genes that is linked to eczema, and there are a lot of studies out there that show that the more severe the eczema, the lower the vitamin D, particularly if the child is breastfed. And a non-soaked toothpaste. Every day we do this, and if they flare, such as they've got rough skin even before the redness comes out, then we use the cortisone creams, wet dressings if they're not sleeping, cool compresses on the face like this little Bubba has here, and antibiotics if they're infected. And anyone that comes into my room that has moderate eczema will go home having a bleach bath that night. So the bath, as I said, is very important, once or twice a day for 10 minutes. The bath helps to physically remove the staphylococcus aureus, or the bacteria that sits on the skin. The cool temperature of about 31, 32, even in the middle of winter, assists in reducing inflammation and itch. The pool salt, as I said, is cooling, antiseptic, anti-inflammatory. We use 100 grams for every 10 litres of water. And bleach, White King, not named after me, but 12 mils per 10 litres, and you can bathe. What I do is I get the kids to swim under the water and to wet the hair as well, because this is an area where bacteria is kept and hangs around, and it's very important to do the face and the body as well. Nice and cool, and it's actually, the bleach is chlorine, so it's actually less stronger than a swimming pool, so it's very safe. And if the babies drink and eat and the older children drink the water, it's not a problem. So in summary, it's reduce the environmental triggers, apply the right steroid at the beginning of the flare and stop when clear, but restart if needed. And then your moisturiser can go straight over the top. Apply the right and regular moisturiser twice a day, and more often when flaring, and particularly more often in winter when there's less humidity. Daily bath with bath oils and salt and bleach if it's moderate. Vitamin D should be thought about, not for everyone, but can be used, and particularly in Victoria. Wet dressings or wet clothes if there's not sleeping and itchy for 3 to 5 nights. Antibiotics if needed, but remove the crust. If they're having recurrent infections, sometimes we swab the nose, and if they've got positive bacteria up their nose, then we'll treat with Bactroban because they can just keep shedding this bacteria. Don't stop foods unless under an allergist's recommendation or supervision. Thank you very much. I'll hand it back to you, Michaela.
Fantastic. Thank you so much for those wonderful insights into eczema, Dr. D'Ambrosis and Emma King. We will now be jumping into our Q&A session. So thank you everyone for joining. And I know you're all itching to ask some wonderful questions. So to start off with, we've had some questions from registrants who aren't able to join us. So we will go through these first, and then we'll jump into some great questions that you've been asking us throughout this session. So I'm going to just unmute our panelists and get them to turn on their webcams just so that we have everyone up on screen. Fantastic. Great. So now I'll be handing over to Cheryl.
Well, thank you, Kate and Emma. That was
absolutely wonderful, and a great way to So sorry about that. Can you hear me now? I was just going to say they were great presentations and answer a lot of the questions we get asked every day. We always point people in the right direction for resources. We also have the bleach bath recipe on our website from the Royal Children's Hospital. But, you know, thanks so much. That's been just some great overview of eczema and great questions answered. We do have some questions that from people who couldn't join us today that registered. So the first one is, my son has bad eczema, which is worse at night. We have a mattress protector, but are hoping you can please help recommend an ideal range of linen, ideally Tencel bed linen. So I'll hand that over to Emma to answer.
Okay, can you hear me? Everyone hear me? Yes, great. So the only mattress protector that I would recommend is something that's 100% cotton, because a lot of the mattress protectors have got the rubber or the plastic in it, so that will only overheat the child. And in regards to bed linen, I recommend everything cotton. I haven't had much to do with Tencel, to be honest, but so I know that Sheridan Outlet has a sale at the moment on cotton quilts. So it depends, I suppose, also where the child lives. But so in Victoria, all of our children will have cotton blankets or cotton quilts and cotton sheets and one layer of clothing to bed. And a lot of the older children will wear summer PJs the whole year through.
Okay. Great advice. So our next question, I think, would be good for Kate to answer is, I've heard that switching from breastfeeding to formula can worsen a baby's eczema. Is this true? How should I transition my baby onto formula and or other foods and minimise triggers and flare-ups?
Thanks, Cheryl. I think, as Emma pointed out in her talk, it can be dangerous to try and put down a child's eczema to food, and that goes for breastfeeding as well. There's no evidence to say that switching breastfeeding to formula causes eczema or triggers eczema or flares eczema. Probably what is more important to look around at the child at the time of switching is what irritants they're being exposed to. Is the skin more exposed to drool or saliva exposure on the cheeks? Are they becoming more mobile at that time? Could that be exposing the skin to more trauma? Looking at things that barrier in replacement mechanisms you could put in place to protect the skin. I think avoiding formula or avoiding breastfeeding for the purposes of eczema shouldn't be our first port of call. There are very rare instances where potentially foods can drive eczema, and that should be managed by a dermatologist and an immunologist particularly, because those types of eczema tend to be very severe. But in the main, eczema is not caused by food allergy. And so I think that's really important, and a lot of my patients take a lot of reassurance that it's nothing that you're doing, nothing that you're giving your child that's giving them eczema, but there are things we can do to help control it and help maintain that skin barrier, and giving them the ability to do that goes a much greater way than telling them things to avoid or stop. So I hope that helps in that question.
That's really great, Kate. We get asked that question almost every day of the week, and parents always feel incredibly guilty that their children have eczema and it's something that they've done. So we have to try and reassure them that usually it's genetic, and maybe blame your family.
Yes, exactly.
So the next question is advice on managing flares in the nappy area. So hand this over to Emma.
Okay, so any bit of skin of the eczema child can be triggered off. So any, from using shampoo, nappy wipes are a huge big trigger for eczema down there. So we don't recommend any nappy wipes at all. Even the ones with grapeseed oil in it, actually that grapeseed oil turns into formaldehyde. So the other thing that I do with Dr. Claire Grills is some patch testing. So we're finding now that a lot of children that are getting older are actually sensitised to products that they've probably been allergic to products that they've been sensitised to as infants. So anything we don't like perfume and things with benzalkonium chloride in can also trigger off another type of rash and the eczema as well. But so in regards to nappies, no nappy wipes, use a Chuck's towel and water instead, a bit of bath oil if you like. And if disposable nappies do tend to be better because they do tend to protect a little bit more than cloth nappy. And if there's any redness or eczema down there, just use a 1% hydrocortisone as needed. And a good barrier cream. So the best barrier creams that I know about are zinc paste that we get made up from our pharmacist. So some olive oil, 10% olive oil and zinc paste, but it is a pharmacy product. It's made up. Or Covertol is a really old-fashioned barrier cream, and that's fantastic. Or just something like a Ken K zinc and castor oil cream as well. So no nappy wipes, moisturise down there, protect with a barrier, and disposable nappies. Yep.
Wonderful, thanks very much. So my next question for Kate is, can a child grow out of eczema? Now you sort of covered this a little bit, but maybe expand on it a little bit more. Thanks, Kate.
Yeah, we do notice that children do tend to grow out of eczema. Usually by the age of 10, eczema will improve, and we think that that's because as the child grows, they're perhaps less, the skin barrier becomes more immune, the skin immunity takes over, and less irritant exposure. So if you can imagine a baby on the ground, there's a lot more body surface area exposed to irritants, ground, sand, salt water, things that they come in contact with like that. So yes, the answer is we can hopefully look forward to the majority of cases of growing out of eczema. And even in cases where the eczema doesn't disappear, it generally improves, and it can be well controlled with a regular maintenance plan and less topical corticosteroid into teenage years.
Wonderful. Do you have any thoughts to add to that, Emma?
No, just that emphasise the fact that most children do grow out of it. The more severe the eczema and the earlier the onset, and if there's allergies at play, these children tend to take a bit longer and require stronger medications to control it and help them, but they won't grow out of their dry skin. That's their lot for life, so they'll always need at least one moisturiser a day, like myself. Yeah, and so, but once again, we have to have a good management plan to help them grow out of it.
Wonderful. So our next question is, and I don't know who'd like to answer this, but has there been any study about the link of probiotics usage to improve eczema condition? So who'd like to answer this one?
I've recently published a systematic review and meta-analysis on probiotics and prevention of atopic eczema. So there's no hope for children that have got eczema now. It's not a treatment for eczema. There's no research to show that it actually helps, but people are still looking into that. But with our publication, we found that there could be a preventative aspect. If a mother takes probiotics during their last trimester and continues to taking it during 6 months of breastfeeding, and the child takes it from day one of birth, but it has to be a mixture of probiotics, and there's certain probiotics, but we still need to do more research on, and preventative is better than treatment anyway, but it's too late for the children who have already developed the eczema.
Well, that's a little bit disappointing because a lot of people ask us about that every day. So my next question is, sorry, I just lost my place a little bit. So maybe with Kate, where do I start? My baby's been diagnosed with eczema. What do I do next? You know, what are my next steps, if you like?
Sure. In a newborn baby?
Yes.
Yeah. So I think firstly, maintaining or establishing a good relationship with your general practitioner, or your dermatologist, is going to be quite helpful in your journey towards managing your eczema effectively. And then I guess 3 main things. So as Emma beautifully pointed out in her talk, not overheating a baby. So maintaining a clothing level that's appropriate for the climate, ensuring they're not causing excess warmth and sweat, which can really drive eczema, particularly in babies. Getting into a regular routine, number 2. So bathing regularly, as with your preferred additives, so whether that's salt, we do a lot of Condy's Crystals addition up in Queensland, bath oil product, and thirdly, and probably most importantly out of the 3 steps, is establishing a moisturising, a skin hydration routine. So adding in a bland emollient to the bath time routine after bathing every single day. And I think with those 3 key things in place, that sets a good cornerstone to hopefully setting up for a good management of the child's eczema going forward.
That's really great advice, because, you know, people often don't know where to start. So it's good to let them know that, you know, we can help them. They just have to persevere a little bit. So the next question is, I need some advice on potty training my toddler. Without pants to protect against the itching, I'm finding he's scratching while going to the toilet. So Emma, any tips?
So to me, that tells me that the eczema is not controlled properly. As soon as a child, so people can take their clothes off and become itchy anyway. But if they're scratching and it's red, first step is control the eczema. So using the right topical steroids, and eczema can occur anywhere and in the genitals, particularly at the base of the penis and the scrotum of a boy. And so we using, make sure you're not using nappy wipes if they're still in nappies, and maybe as soon as they take the pants off to moisturise. Penis and scrotum can also be moisturised. And another good thing is the French again have got thermal sprays. So the French government paid for children in France to bathe in mineral salt water So what they've done is they've canned it, and we have it in a can in Australia. So it's also important to teach children not to get into the habit of scratching. So we use these sprays, these thermal sprays, and so it might be good. So they're cooling and they've got salt in, so it's just salt water, mineral salt water. And so maybe even just spray that area before, just as soon as you take the pants, then spray the area and pop them on the potty and moisturise.
And I think, just sorry to jump in, Emma, but also I think a good additive for kids, particularly early on, if they've got severe eczema that's going to be enduring through their childhood, is teaching that behavioural response. So tap, not scratch. So really getting them into the ability to recognise itch, tap the skin rather than traumatise it. And I think that goes a long way towards protecting the skin barrier as they get older.
Yeah, we find one of the problems is with kids yelling at them not to scratch. You might as well say don't breathe. So, you know, distraction or teaching them different techniques can be quite useful. So my next question is, for clients that prefer non-pharmaceutical products topically, what would be recommended? I understand these are usually not evidence-based as non-patented, but I have experienced good results with aloe vera. So who would like to answer that one?
We can both jump in. I think any emollient on the skin when you've got a skin barrier issue or pathology is helpful. So you know, it may not be evidence-based and it may not have a big drug company name behind it, but as long as the skin isn't reacting and isn't allergen sensitized, which you can generally tell within 2 or 3 applications, then putting a skin barrier product onto skin that is barrier impaired will be helpful. So I think from my point of view, that's fine.
So with our patch testing clinic, aloe vera and calendula are one of the few that in the top. So we actually say no plant products on children's skin because you're actually going to potentially, with their sensitive and dry skin, set them up for a contact allergy eczema later on down the track. So natural is not always better. In fact, cortisones, we all make cortisones, you know, via our kidneys, and so cortisones are in fact probably the most natural thing that we can put on the children's skin. So stay away from perfume, stay away from plants, and stay away from foods in creams because they may be in nature, but it's not often what the skin needs because it's not natural for us to put plants on our skin. We're not plants to put plant products on our skin. And in fact, if you put things with food in them, you actually can set them up for an IgE-mediated allergy, particularly if they're babies. So we say just use bland products that are non-perfume without food and plants as an ingredient.
And I think sorry, I took that as Cheryl saying that they had to put something on the skin, which I think is better than nothing, but also checking the skin for the response. So not just putting anything or a product, a plant-derived product on, and then reapplying without being mindful of how that skin is responding. So I think that's really important to gauge.
And I think too, one of the things we always advise is patch testing anything new first. Doesn't matter whether it's bland or plant-based, you know, do a little patch test first and leave it and see if the child reacts before you spread it over a bigger area. It just, you can tend to get better results that way. I'm an eczema sufferer, so, you know, I know how it sort of goes.
Particularly on normal
so
skin.
I think that's all our questions for now, and I think we've reached the end of our webinar. I'm going to hand you back to Michaela to finish off. Thank you.
Thank you.
Fantastic. Thank you so much for that wonderful session, panelists, and for all your questions. Please note if you haven't answered, if your question wasn't answered, please send it through to corporate@eczema.org.au. We will try our best to have all your questions answered. But I guess that's time in our eczema and babies live Q&A webinar. Thank you to everyone who registered and joined us today, and thank you to those who weren't able to be here but still registered and asked the questions you've been itching to get answered. Thank you also to our amazing panelists, Dr. Kate D'Ambrosio and Emma King, for donating your time and providing some really great insights into how you can effectively manage your child's eczema. As mentioned earlier, we have a 5-minute post-webinar survey we would appreciate if you could please fill out to help us understand how you found this session and to help us get an idea of what you would like to learn for future webinars. If you could also complete the survey, you'll be included in the virtual goodie bag that all our wonderful partners have donated to, supplying a range of discounts and goodies to help you manage your eczema over this season. There will also be a random draw raffle prizes, which are amazing. Thanks again to our corporate partners. So we'll be sure to be in touch with you in early March if you have been announced as one of our lucky winners. I really encourage you to fill out this survey because some of the raffle prizes are amazing. The video recording and handouts will also be distributed to the emails you signed up with for you to refer to in future, and be sure to share with your friends and family and colleagues as well. Thank you again for your participation, and make sure you enjoy the rest of your day. Thank you, everyone.